Hi everyone, my name is Misbah Faiz and I am the project officer for the Sphere Palliative Care Clinical Academic Group. I'll be presenting a case study today that was a quality improvement project that was coached through the Sphere Stanford Quality Improvement Initiative. And this project actually sought to improve electronic medication record documentation of nursing plan of care to improve Southwestern Sydney Local Health District's after hours palliative care service. So just a bit of a background on the after hours palliative care phone service. In Southwestern Sydney Local Health District, patients that are known to the Community Palliative Care Service are able to access advice and support in the after hours period through the after hours palliative care phone service. These calls are answered by palliative care nurses working in the palliative care units, which are located within hospitals in that region, and the nurses rely on electronic medication records that are written by the following services, which you can see on this PowerPoint here, and they use that documentation to provide advice to patients. So the issues that have been identified in the after hours period include challenges that the nurses working in the palliative care units face in giving advice and recommendations, and that's due to a lack of information. So a patient that's registered with the palliative care service, their information is held in electronic medication records, and the after hours nurses do have access to provide advice through what is written in these medication records, but they rely on the fact that all of these services here, they are drafting nursing plans of care and other documentation. And the location of this documentation can be located in multiple different folders in the electronic medication record. So as this presentation goes along, I'll be referring to the after hours palliative care phone service simply as the after hours service. And let me tell you more about the project. So through the coaching that we received from Stanford, we were able to devise a very specific and targeted SMART goal. So as we noted, the nurses answering the calls in the after hours service were facing problems that limited their ability to provide tailored and appropriate advice in the after hours period. And through the coaching that we did receive, we actually sought to increase the percentage of patients with a suggested plan of care that have these three components. So the first being, it has been documented in the nursing plan of care folder of the electronic medication record. It contains the prompts name element, which is a mnemonic that is used to document symptoms, which I have spelled out here in the PowerPoint, and also a follow-up management plan. We aim to take it from 20% to 40%, so essentially double our compliance by the end of the program, which is July 30, 2021. So we actually undertook a root cause analysis by drafting this fishbone diagram, and our team was actually able to identify the main factors that contribute to the issues that relate to, advice that's provided in the after hours period. So interestingly, our initial assumption was that an intervention would be designed to target the nurses that actually work in the palliative care units and provide this advice to patients. But through the coaching that we received, we actually realized that if we address EMR documentation and all of those stakeholders that write it, that was actually going to be not only more feasible, but more impactful to actually instigate change in this project. So from our fishbone diagram, which we just saw, we were able to determine our area of focus, which allowed us to create our key drivers. So as you can see here, the key drivers actually focus on creating and implementing documentation guidelines for community palliative care patients, and also providing education to the community and after hours nurses on this new process of where documentation should be kept in the electronic medication record folder. So just to present some baseline data here, we conducted an audit of the after hours phone calls to determine how many met the requirements of our SMART goal. And we found that only 20% of the documentation was located in the correct EMR folder. It had the PROMS name element, and it also had a management plan. So that's what our baseline data was, and we were looking at designing interventions and seeing the level of improvement we would see. So in terms of interventions, I just have here the key drivers and how we designed interventions. So it was through looking at our interventions, we created an EMR folder location guide and an EMR folder documentation guideline. And just also to note in this diagram, you can see that there is an X on our third driver here, which refers to the electronic medication records driver. But through this process, we realized that we can't change this software program that's used across the whole district. So therefore, even though it is a key driver, it's something that we can't address. So we had to abandon that in terms of designing an intervention. So just to see how our project performed. So initially, as we mentioned, we had a 20% baseline. And our first intervention was actually a communication campaign. And we actually communicated to a lot of key stakeholder groups that we're actually going to be rolling out these guidelines to the key stakeholder groups. But in that communication, we actually just said, this is where it should be located and this is what the documentation should contain. And that was to, a lot of senior executives, to the nurses themselves and all the stakeholders in between. And through that communication, you can see we have a slight increase in compliance. The next intervention that we designed was an education campaign. Essentially what we did was we just looked at what education was occurring for nurses across the region, and we just actually joined those education sessions, and we just talked about where EMR documentation should be located and what it should contain for community palliative care patients. We also sent some emails out, and we actually got nurses at each site who just talk to their colleagues and educate them about this new initiative. And as you can see, after delivering that education campaign, we can see another increase. So finally, we launched our documentation guideline, which is actually quite towards the end of this project. And we can see that there is kind of a steady state there. And as we mentioned, the target, which you can see here, is to reach 40% compliance. But in fact, by the end of the program, we actually reached 73% compliance with our SMART goal, which was a really great outcome. I would also just like to share some additional results from this initiative. It went really well, so more guidelines were developed to assist other stakeholder groups such as community nursing, after hours palliative care, nursing, and here where they talk about PEACH, that's our palliative care home support packages, and we have nurses that deliver that, so a guideline for that group as well. In terms of institutional impact, the impact of this project has far greater impact than just those patients that are known to the after hours service. The intervention that we created and we implemented, it showed that improving documentation, it improves care for all of the patients that are known to community palliative care. And just to give you a snapshot of how many patients we're talking about, in the financial year of 2020/21, we received 3,455 referrals. Improving documentation also has implications for medical reviews and outpatient settings, and also for the emergency department. So there is that flow-on effect as well. This is just another slide to just demonstrate that we are looking at making sure these changes that we made have a long-term impact, and we've developed a sustain plan. It consists of 3 components here, which is creating a checklist, embedding this checklist, and conducting snapshot auditing. And we've detailed owners and who they report to and what the method is. So just wanted to finish up with some key learning points. So the team here was really able to see for themselves that the small changes that we implemented actually resulted in really big improvements. And one of the reasons we actually noted this project was so successful is because we did have a lot of buy-in on that project, because we were able to demonstrate the value and the impact that undertaking this QI project will have. And another thing that we did notice is by going through this program and understanding evidence-based quality improvement, we could reflect on previous projects and understand why they weren't so successful. So our next steps include improving documentation in other settings. So we're talking about transfer of care and in the acute setting as well, reviewing documentation by specialist palliative care in acute settings and expanding education and awareness into other departments. I'm also pleased to announce that we are launching Program 2 of the Stanford Quality Improvement Program, and a team has actually been accepted, and the project that they have proposed is improving documentation at the transfer of care and reviewing documentation in the acute setting. So it's some really great outcomes from this project. So thank you. And if you have any questions, I'm happy to answer them.
Thank you, Misbah.